Morning, everyone. Welcome to Grand Rounds. First, let me say that I'm grateful to our speaker for filling in today because Myrna Weiss was scheduled, but she was skiing and had an accident and therefore was unable to present today. But I'm sure we'll find another occasion for her to give Grand Rounds. Next week, we have Grand Rounds given. This is the annual Sackler Institute Grand Rounds, and it'll be presented by Dr. Declan Murphy, who's a big deal in UK in cognitive neuroscience. And he's at King's College and will be speaking on translating novel treatments from the laboratory to the clinic quickly and relatively cheaply, a delusional idea. Sounds like we should have him testify before Congress. Couple of announcements before introducing Dr. Smith. Claudia Lugo Candelas received a KO8 from the NIMH for support her work on longitudinal study of perinatal maternal obesity and fetal origins of impulsivity in Puerto Rican children. Christiane, are you the mentor on that? Okay. Jonathan Posner, Larissa Tasker, and Adi Talati received a 5-year R01 from the NIMH for a study of effects of prenatal maternal depression and antidepressant exposure on offspring neurodevelopmental trajectories, a birth cohort study. So congratulations to them. And then we have some announcements of some of our House staff who have been recognized for various distinguished purposes. Catherine Kahn Fuller, PGY2, was elected to the position of, hold your applause till the end, there's a few of them, position of Deputy Representative of Resident Fellow Members of Area 2 of the APA. Oh, politics, okay. But that's good. Nicole Pacheco, PGY1, has won the APA SAMHSA Fellowship Award. Ramon Burgos, PGY2, has won an APA Child Adolescent Fellowship. And Teber Lightborn, PGY2, has won an APA Diversity Leaders Fellowship. So that's great that we have such representation and taking advantage of these APA awards. If you haven't voted for the U.S. News and World Report Best Hospital, you should, because I'll get yelled at if we don't have 100%. And also, we have a CME event coming up. It's free. Free. It's being sponsored by Columbia Psychiatry and specifically by Vice Chairs Lou Baptista and Melissa Arbuckle. It's going to be here next Saturday. It's an all-day event. Clinical experts from our faculty speaking on topics ranging from substance abuse to DBT to women's mental health. And there's flyers around. It's on the website. So it's an opportunity to come here, get CME credit if you want it, but to listen to some of the faculty talking about not necessarily research, but basically clinical topics, and they're going to feed you as well. So I think that's the first of these we've done. Is that right? But hopefully it'll be well received, attended, and we'll do more. So I'm going to take a couple of minutes to lavish some praise, and not to embarrass him, but really just to reflect my sincere feelings about Tom Smith. Tom is a faculty member of ours. He's been in the faculty since 2007. And the reason is I want to make the statement is that he represents something that is really, I think, exemplary and is also quite unique and illustrates the best of what Columbia Psychiatry, NISP are intended to do, which is to use psychiatric medicine and the associated disciplines to further the cause of mental health care at a population level and in the public sector. And that really was the spirit in which this department and its state support through NISP was established. And even if you don't know it, this actually goes back to a visionary politician, surprisingly, over 100 years ago, that decided that mental illness needed to have a research focus, that it likely emanated from the brain, and that to do it, you should really leverage the intellectual resources of a university. And so the university donated the land, the state put up the money, and that Psychiatric Institute was born, and it became a public academic partnership that's flourished ever since. And we get a lot of money from New York State through OMH, and the way we repay our debt is in a number of different ways, including training mental health professionals that go out into the workforce to minister to the citizens, to do research that informs the nature of the mental health services that are provided. But also, we offer up our faculty to assume positions within New York State's agencies dealing with mental health. And Tom is really an exemplar of that. And an exemplar in the sense that, as you'll hear in a moment, he's done various things in different sectors over the course of his career, but this is where he is now, not because it was the most lucrative thing or the most easiest thing or the most glamorous thing, but because this is where he wanted to be. So I'm guessing you're from Michigan originally? Mm-hmm. Tom hails from Michigan. He went to the University of Michigan, go Blue, for undergraduate school, then Wayne State Medical School. And he came and he did his residency at the University of Chicago, and he was a chief resident. And then he came east, where he joined the staff and faculty at Cornell and New York Hospital, Westchester Division. And he was there for a period of over 10 years, almost 15 years, where he served in a variety of capacities, including as director of the Schizophrenia Disorders Program and director of the Continuum Division of New York Presbyterian Hospital, Westchester Division. He then did a stint in the private sector in mental health administration as medical director for Hallbrook Behavioral Health Services in Connecticut, and then interim president and CEO of Hallbrook Behavioral Health. But in 2007, he came to Columbia. And at Columbia, he was recruited into Susan Essex, then founding division of Services and Policy Research, and began pursuing sponsored research in mental health services. Somewhere, I think along the way, 2009, I think it was Mike Hogan and Lloyd Sederer drafted him into a role with developing a program, a pilot program in Brooklyn to monitor recidivist patients that had violence or threat potential. And this was in the period which, wasn't confined to just then and continues now, where there were episodes of violent attacks by mentally ill individuals on persons, either individually or in a mass basis, and there needed to be a response to it, and Tom was tapped to sort of do that. He did such a good job at that they kept him, and he migrated through a couple of roles into associate medical director of OMH, working with Lloyd Sederer and Michael Compton, and now is deputy chief medical officer, but come April, no matter the fact that it's April Fool's Day, he's going to be the chief medical officer for OMH and New York State. So whereas he was in our faculty and I was his boss, now he'll become my boss. But it's a good thing to have. And it illustrates the way that we have over the years really provided individuals in the workforce, but also in leadership roles in New York State. And so we're genuinely giving back. It's not an ivory tower operation where we take the money and say, thank you, don't call us, we'll call you. We're really, integrally involved and substantively contributing. So Tom has, throughout his clinical work and public service, also been active academically. He's conducted sponsored research funded by a variety of organizations and currently is funded through SAMHSA as a co-investigator on a grant Building Sustainable SBIRT. It stands for?
Screening and Brief Intervention
screening and brief intervention in integrative hospital systems in New York. He's also the principal investigator of an R01 on hospital discharge planning and transition to outpatient psychiatric care. He's a co-investigator with Bob Drake on a Social Security Administration contract for supported employment demonstration, and he's a co-investigator with Scott Stroop and others on the OPAL grant, which is optimizing and personalizing interventions for schizophrenia across the lifespan. Now, Tom is, in addition to doing his research, has also, as academics do, written about it and published numerous publications, chapters, and so forth. His actual first paper was when he was in college on the ontogeny of endocrine control of osmoregulation in chick embryo. I guess we're going to have to get you a laboratory in addition to the office. But then he quickly moved to psychiatry and focused on research involving rehabilitative services, pharmacologic treatment, and systems for largely severe mental illness. So, as I said, it's really a pleasure to have been able to provide an academic platform for Tom to pursue his career, and now to hear him describing some of the research he's done on measuring behavioral health treatment quality and performance. When and why does it matter? So please join me in welcoming Dr. Tom Smith.
Thanks, Jeff. Hi, everybody. Such a glowing introduction. Would it have been as glowing if I were not about to become your boss? Don't answer that. Not quite. You left a couple of things out. So, unless our commissioner has the world's most perverse sense of humor, I will become the chief medical officer on April Fool's Day. So that's next Monday. So, and I echo everything Jeff said in terms of having the opportunity to be both a faculty member and part of this wonderful group of colleagues here, and at the same time to serve the state and serve the Office of Mental Health in a capacity that helps promote the great work that's done here, but also provides an opportunity to have a real public health impact. I think I have a great job, and I'm very grateful for the opportunity to have it and to be part of the group. So that said, let's jump in. I thought I'd pick a topic that was relevant to it should be relevant to many people in the room, including especially those who practice regularly, but also very relevant to the Office of Mental Health in the state, which has to do with this notion that we can and we should be defining and measuring quality, performance, and value at all levels of our healthcare and now behavioral healthcare system. It's a very interesting topic. There's some very fundamental reform going on in the healthcare system that I think should be relevant. But you'll tell me. So what I'll do today, I'm going to start with a background on healthcare reform that over the past 20 or 30 years that talks about how the stage has been set from this move to, from volume-based approaches to value-based approaches for paying for health care. And then we'll switch gears and talk about behavioral health performance measurement. Where are we in the field? And then the short answer is we're not very well developed at all. We lag behind the rest of medicine in terms of how we're measuring performance, quality, and value. And then based upon that, I'll end with some ideas about where we're at right now, both here at Columbia and in the State Office of Mental Health and elsewhere, with initiatives to try to move this field forward. And I'll show some data. We don't have a lot of data because we're just getting going, but I'll show you what we got. So why do we measure quality and performance? Why do we measure things? I think it's interesting that I'm asking that question to an audience at the premier psychiatric research institute in the world. I think people in the room probably believe in measuring things. I hope you do. There's a number of reasons why we measure things like quality and performance. One is we do research, right? We want to understand things, whether it's mouse brains or how treatments work or how systems of care work when we start getting to the Office of Mental Health. So we do a lot of this, monitoring systems, providers, populations, right? We measure quality and performance as part of what, broadly speaking, we call internal quality improvement. By that we mean as an effort to look at what we're doing, whether you're an independent practitioner, whether you're a clinic, an agency, whether you're an insurance company, right? How are we doing? What standards have we set for our performance, and how are we doing? So you do clinical CQI, continuous quality improvement, you do measurement-based care, et cetera. The insurance companies in New York have to do performance improvement. So it's an opportunity to look internally and see if you're meeting your standards of care. And what's most interesting now, the real push for measuring quality and performance, has to do with accountability. And this is what we'll talk about today. This is what's going on in our healthcare system. There's an increasing emphasis over the past 10 years on holding the system, providers, insurance companies, whomever, accountable for outcomes in healthcare. And the way that's done, there's a number of ways. The most common, the initial way is just public reporting, right? Report data on outcomes of care so you can either shame or reward providers or agencies or programs, et cetera. And then now what we're seeing is this value-based payment. So you can actually link quality to payment, right? This is the fundamental shift that's going on in our healthcare system, the shift towards paying for volume to paying for value. You know, the traditional healthcare system has been a fee-for-service system, right? You deliver a service, you send a bill, you get paid, right? So that kind of program emphasizes volume. The more services you deliver, the more you get paid, right? So that there's this shift now to, instead of just paying for volume, let's pay for value. But that means we have to start measuring value. And let's see if we can link payment and reimbursement and redesign to actual the quality and outcomes that we're looking for in our healthcare system. That's the fundamental change. So going back, I think this goes back about 30 years, the initial efforts to look at how do you incentivize and pay for quality and outcomes in healthcare. Initial efforts were in the early 1990s. This was not in behavioral health. For the next 10 minutes, I'm not going to talk at all about behavioral health. This was in general medical care, where insurance companies and some state, federal payers got together and started thinking, let's incentivize or let's pay payment. Let's tie dollars to some outcomes. So the initial incentive programs were in large primary care practices. Could providers, primary care providers, get bonus payments for doing things like making sure immunizations and screenings, et cetera, are accomplished and documented. So there were initial efforts in the early 1990s, They weren't very effective, actually. The initial research suggested that they didn't necessarily move the needle on quality. And that's one of the themes I want to come back to a couple of times in this talk is does this work? Does this shift from value to volume, from volume to value and paying for quality, paying for outcomes? Do the tools we have to do that, do they work? Do we actually get better outcomes if we do that? So these initial studies were not very exciting. They didn't show that all of a sudden quality improved dramatically if you started paying for these things. And there were all sorts of reasons why. There's selection bias issues. What were the incentives? Exactly how much money should you pay a doctor to get the doctor to do better care? There's this debate about intrinsic and extrinsic motivation. A lot of doctors are put off by the notion that, well, if you pay me more, I'll do a better job. That's not why we went into this. We went into this field because we want to treat our patients. And I do as good as I can with every patient, regardless of what I get paid. So what makes you think that paying me more is going to get better outcomes, right? So all sorts of issues like that came up. But they didn't drop it. The experts in the field, whether it's the federal experts or insurance companies, they didn't just drop this notion and walk away from it. And the reason for that is cost. People have seen these data before. In the United States, we spend an extraordinary amount of money on health care. These are data comparing to similar countries on our percentage of our GDP that's spent on health care. And we're way, way above similar countries and have been for a long, long time. So the cost of health care in the United States, people know this, has escalated at almost uncontrollable rates. Starting to get better, but throughout this entire period, this is very alarming. Okay? But we don't necessarily get better outcomes. We pay a lot more in this country for health care, but our outcomes, depending on what you look at, are right in the middle or average at best compared to similar countries. Here's a picture looking at healthcare expenditures per capita on the x-axis here. So you can see the U.S., this red line, right, is much higher, up by 2014, over $9,000 per capita expenditures on healthcare, much higher than any similar economies or countries. But looking at our average life expectancy over time, we're in the middle or below our peers. Okay, so we're not getting the outcomes. I could show you a similar picture with infant mortality. I could show you a similar picture with suicide rates. We are in the middle at best compared to our peer countries or similar economies in terms of our outcomes. But we spend much, much more, often more than twice as much as similar countries on healthcare. You know, this graph looks at 11 countries, compares 11 countries of similar economies, including the U.S., on a number of indices of quality of care, access to care, efficiency, equity, et cetera, and ranks every country in each of these domains. And with an overall ranking, and U.S. comes in at the bottom, dead last. But our costs, per capita costs, more than twice as much. So that same point being made, costs escalating out of control, not getting the outcomes, what's going on. So there were a couple of monographs and reports. The Institute of Medicine weighed in on this in 2001 with the Crossing the Quality Chasm report. By 2008, we had this notion of the triple aim coming out. People have probably heard of that. You know, Donald Berwick and the IHI group talking about the healthcare system that needs to attend to all three of these domains at the same time: population level health, individuals' experience of care, and cost. And all three matter. And if you will, this is the definition of value, is actually outcomes or quality, right, whether it's experience or health, divided by cost. That's sort of a very broad economic notion of value. So high value interventions or programs are those that can touch a broad population, touch a lot of people, and have a high quality impact, but don't cost as much. So things like immunizations, preventive care, cancer screenings, et cetera, are very high value costs, or high value interventions, right? The kind of heart transplants that are going on across the street at New York Presbyterian are somewhat lower value. They're very, very higher cost. They don't touch a lot of people, et cetera. So that's this notion of value. So the experts started running with this, the experts including the payers. So by the early 2000s, you started to see hospitals and CMS, Centers for Medicare and Medicaid Services, jumped in right away. Said we need to start tracking and reporting quality. By 2002, in the Hospital Quality Alliance, a number of hospitals volunteered to start reporting quality measures, publicly reporting them. CMS jumped in on that, and by the early 2000s said, well, hospitals need to participate in this public reporting program if they want to get their annual CMS updates. So they essentially mandated it. By 2003, we saw the first premier quality incentive demonstration where a number of hospitals, I think 26, got together and agreed with CMS to participate in a program where they would be eligible for incentive payments based upon the publicly reported measures. And that started from 2003 up for 5 or 6 years. Here's an example of the measures. People have seen or heard about these measures. They did not focus on behavioral health. Behavioral health is off the radar at this point in time. So this is looking at AMI, myocardial infarction, heart failure, pneumonia. People have seen these measures. The residents who've worked in the ER in your internships, you remember this stuff. How many people are getting aspirin on arrival to the hospital with a heart attack? How many people are getting beta blockers right away? How many people are getting antibiotics for pneumonia within 4 hours of arrival at the hospital? These are sort of process measures that were initially put out there, relatively easy to measure, and put on hospital reporting websites through CMS. So what about it? Did it work? Right, we're back to that question. Does this work? Here's some data. There are a couple of papers published by 2007 or so looking at these different conditions, myocardial infarction up here, heart failure, pneumonia here, and then the composite, this bottom right graph. And this compared the hospitals, all these hospitals were publicly reporting. So comparing all hospitals publicly reporting against those who actually were publicly reporting and getting the incentive payments if they hit benchmarks or targets for quality. And by and large, the hospitals that were getting the pay-for-performance incentives tended to show greater improvements over time in these quality measures, the one we just talked about. They were not significant for myocardial infarction. They were for the others, but the findings were not robust. And perhaps more importantly, when you looked at the outcomes that matter, things like mortality, hospital readmissions, they did not find significant associations between the incentive payments and the outcomes. So we still have this lingering question, does this stuff work? That didn't stop us, though. I mean, once again, remember, costs are escalating out of control by 2005 to 2010. The federal government jumped right in, all the way in the deep end with these kinds of programs. The Deficit Reduction Act, this was under the Bush presidency, was the first time where CMS was asked to develop a hospital value-based purchasing program by 2009. By 2008, we had the Obama administration, we had the Parity Act, High-Tech Act, which created funds to support implementation of electronic health records in hospitals. So these opened the pipeline for dollars so that now our friends at Epic and Cerner can control our lives, right? The Affordable Care Act by 2010, or what we call Obamacare, which is alive and kicking as we speak, right? Was all about Medicaid expansion, creation of exchanges, et cetera. But what people don't talk as much about with the Affordable Care Act was the mandate to create a national strategy to improve delivery of health care services, outcomes, and population health. So this major push over the past 10 years has been driven by provisions in the Affordable Care Act. So things like the health home programs nationally, DSRIP, several states have DSRIP initiatives, including us. New York State has an $8 billion DSRIP program for CMS that came through the Affordable Care Act. A lot of the Medicaid managed care reform, and a lot of these value-based initiatives are funded and supported through the Affordable Care Act. Here's some examples of some of these programs. I'm not going to go through all these, but you probably recognize some of these. The physician and hospital quality reporting systems, bundled payments, EHRs through high tech. ACOs, we'll talk a little bit about accountable care organizations. So by 2010 to 2017 to the present, right, CMS jumped in in the Medicare program especially, not so much in Medicaid, but in Medicare, and supported the notion of accountable care organizations, which are large provider networks, including providers of all types, primary care, specialty, hospital, et cetera, that would come together, form an ACO, and contract with an insurance company or a payer for a lump sum of dollars to cover a number of lives, right? And they would have targets set for how much it would cost and for quality measures associated, and based upon the targets, there could be savings generated by these ACOs. That's the ACO model. A lot of people might not realize it, but as of last year, 2018, 90% of Medicare payments to providers in this country were linked in some form to quality or value initiatives like these ACOs. So CMS has really jumped into this. Here's the model. Let's spend a little bit on this accountable care model, because this is the value-based payment scheme that we are also using in New York State, in the Medicaid program in New York State. And this is what we're working with the Department of Health. We, OMH, our sister agency, OASIS, we're working with the Department of Health on how to implement this model and restructure payment schemes in the state's Medicaid program. The idea here is you pick an illness or a procedure or an episode or a population. So an episode of care might be maternity care. So let's pick maternity care. How much does it cost? Let's start by identifying the cost. How much does it cost to take care of, to provide all care related to an episode of maternity, from pregnancy through childbirth, right? Or it could be a procedure. It could be a hip replacement or a knee replacement. How much does it cost to replace a knee from the date of surgery through 12 months, for example, covering all the physical therapy, right, et cetera, all complications, et cetera? Or it could be a population. How much does it cost to provide all health care to an entire population of 50,000 people enrolled in a particular insurance plan over a 12-month period, right? So you pick an episode, a procedure, or a population, and you identify a baseline budget. How much does it cost to do that? Per member, you hear about PMPM, per member or per person per month. How much does it cost to take care of them? Sounds complicated, but it's not that complicated. What you do is you go and you look at the past couple of years, past 2 or 3 years, how much did it cost? Look at the claims data, Medicaid data, whatever you have, and you figure it out. You say, okay, so we know how much a knee replacement cost us in the past couple of years. Okay, so you have a baseline budget. You can adjust that up or down based upon trends or incentives you want to introduce to it, but you end up with a target budget. Then you go out to your provider network and say, we're going to contract with you to do maternity care and over the next year. And we have a target budget based upon what we know of the past couple of years. Here's how much it costs typically to provide all care for a pregnancy and childbirth. We're going to contract with you. You're going to provide this care to a population, and we're going to pay you in a fee-for-service model. You send in your bills for all the checkups, all the blood tests, ultrasounds, delivery, hospitalization, complications, and we'll pay you for all of them. But we're going to track, in the end, we're going to track how much it costs per maternity episode. And you're going to track it too, because you're contracting with us, and you're going to want to know how much you're spending. So you, provider, are going to be motivated to pay attention to how much care you're delivering, because we're going to track your actual spend, and we're going to compare it to your target at the end of the year. And if your actual spend comes in below the target, right, then we're savings, because we're going to set aside this target. These are the dollars we're going to set aside. We're going to put them in the bank. Right, we're going to set these dollars aside. If the actual spend comes in below, we have savings here. We got dollars in the bank we didn't spend, and we'll share them with you. You, provider, can keep some, depending on the arrangements you make, you can get those dollars. So that's your incentive. That's the model. Now, the best way to succeed at this model, what's the best way to win if you're a provider? Don't provide care. Ratchet down how much care you give, right? Bring that performance down so you're not spending money and you got money in the bank that you can share, right? This was the original managed care model in the 1980s, 1990s. This was the model, the idea, give the dollars to managed care companies and have them manage the dollars. And the notion being that if there was a laser-like focus on cost, right, that would incentivize managed care plans to ensure that everyone got the highest quality care. Because the highest quality care is going to end up with the lowest cost. So that was the original model. It works, it kind of works in medical care. We talk, because in medical care, you think about diabetes, cardiovascular disease. It's a fairly closed system that if people are not getting the best care, right, if you're not getting good diabetes care, you're not getting good hypertensive management, you're generally going to get sicker. Right? And if you get sicker, you're going to end up back in the emergency room, back in the hospital. Your care is going to get more expensive, and you're going to stand out. And there's going to be a pretty clear relationship between not getting good care and becoming more expensive. So it kind of worked to a degree in medical care. It failed miserably in behavioral health, right? And these are the horror stories from the 1990s, 2000s, and why most of us in this room to this day as psychiatrists can't stand managed care, right? And what I'm most proud of, I think I can say this. It's a joke, but one of the things I'm most happy about getting a new title next week as Chief Medical Officer is that I'm going to drop one of my old titles, which was Medical Director for Managed Care. OMH made me have that title for 5 years. I said, you can't do that to a psychiatrist and put them in charge of managed care. I have all my peers and colleagues who are going to ridicule me. So what happened in behavioral health, if you withhold or deny care to people with serious mental illness or even mild to moderate conditions, they don't necessarily stay in the system. They get sicker, but they leak out of the system. Some people with serious mental illness go up to their parents' attic and they hang out there for 20 years, right? A lot of people ended up, we know where they ended up, jail and prison, right? A lot of people ended up in shelters, on the streets, homeless. What happens when you go in jail or prison or become homeless? Your Medicaid gets suspended, you get disenrolled from the managed care plans. So the managed care companies look at that and say, wow, these costs went down to zero. This is great. Our focus on managing costs has been fantastic. But what did we see? Behavioral health spend went down almost to zero, and we have all these nightmares that we've been living with. So if you just ratchet down care, it's not going to work, especially in behavioral health, which is why we have to add in quality and performance measurement. So the idea here is if you get more efficient with your care and your spend goes down, you can share in the savings as long as you hit our quality targets. As long as we are confident that you are providing the quality of care that we want, that you're meeting our standards. So hence this emphasis now on performance measurement. So we have to start measuring things. What are the standards, right? Before we jump to behavioral health, just again, this question, does this work? Does this model work? So we now have over 500, 600 ACOs, accountable care organizations, contracting with Medicare nationwide in the past 5 years. Here's an example of ACO performance measure set that CMS has promoted, put out there. It's, a lot of it's population health-based, has to do with vaccinations, cancer screenings, screening and management for diabetes, hypertension, et cetera. One measure related to behavioral health. Depression screening. Are people getting screened for depression? This is a measure set that goes back 5, 6, 7 years. So very little focus on behavioral health. Here's this does it work question. These blue dots here, each blue dot is an ACO, an accountable care organization. They had a contract with Medicare to provide services in a shared savings program. And on the x-axis here, it's looking at aggregate quality scores. So as you go out to the right, your quality is higher. Your quality ratings, your quality scores were higher. And on the y-axis here is a cost, or how many, did you generate shared savings, right? Or did you lose money, right? Because that's the flip side of this shared savings model. If you spend more money than the target budget, tough luck, you lose. You have to eat those dollars, which is a hard thing for providers to understand. You don't see a clear relationship here between improved quality, right, and shared savings. Once again, we're not really seeing it. So does the fundamental model work is still an open question. Here's here's some trend data looking at introduction of VBP patient experience measures. We'll talk more about a subjective experience of care. But it was 2011 where they introduced patient satisfaction, patient experience measures into the VBP measure set, looking at rating measures of patient satisfaction, patient experience in hospitals participating in the payment programs versus all hospitals, because these data are available. There's no meaningful change over time once the measure was introduced. So once again, questions about the impact. Not to be overly pessimistic, there are data now coming out that show that the longer you stay in a value-based arrangement, whether you're an ACO, provider, et cetera, the longer you stay at it, the greater the chance that you're going to start moving that needle and really generating savings related to quality. So I think that's one of the take-home messages. These programs are not quick fix programs. They take a long time, and I think we as a system, and this is what's happening in the United States, you have to commit to it over the long haul and let it unfold for 10 or 15 years, but that's what's going on. So going back now, let's get to behavioral health. As of 2014, 84% of these ACOs, contracted ACOs, included the dollars for behavioral health in their budget, right? When you sign a contract, you say, I'm a provider, I'm going to provide these services. You can say, I'm only going to do this, I'm not going to do behavioral health. You can say, I'm an OBGYN practice, I'm going to do maternity episodes, but I'm not going to do primary care. You can pick and choose what you contract for. So 84% of these ACOs, they put all the behavioral health services and behavioral health populations in their contracts, but only 14% actually had described an initiative to try to address or improve behavioral health outcomes. So they're in there, but no one's working at it, okay? But what did we start to see? Right? So this is, now we're into 2014, 2015, 2016. As these models are starting to mature, the entities, stakeholders say, boy, this is a little bit harder than we thought. We're committed to it, but where are the dollars? Where are the opportunities for quality? And this is where mental health and behavioral health start to really come to the forefront. People have probably seen these data, the impact of behavioral health conditions on costs and outcomes, mental disorders. I'm not going to go into too much detail with these, but mental disorders right at the top in terms of accounting for and driving total healthcare costs. People have probably seen this as well. Mental health and substance use disorders responsible for the greatest amount of disability in our country as a single disease category, right, compared to cancers, cardiovascular disease, et cetera. Think about it. Serious mental illness, depression, schizophrenia, bipolar disorder, these are conditions that often have an early age of onset, right? So people are in their late teens, early 20s, they get schizophrenia, they get bipolar, they become disabled, and then they live another 40, 50 years with that disability, as compared to cardiovascular disease, tumors, diabetes, et cetera, which tend to have onsets later in life. And people don't live 50 years like they do with serious mental illness. So in part because of the nature of the disorders themselves, but also because of the age of onset. We have an extraordinary amount of disability in our country that's accounted for by behavioral health. So the powers that be, you know, we smile and say, yeah, we always knew that. But the powers that be, whether it's the feds or these large hospital systems, these accountable care organizations, they started waking up and looking at this and saying, you know what, behavioral health is really driving a lot here. Here's data from 2014. This is New York State, so this is when we were planning Medicaid managed care reform and really diving into DSRIP in 2014. It's a busy slide, but it illustrates a point that's been demonstrated a number of times nationally. This is the 2014 New York State Medicaid population, about 5 million people, and 20% of them had a behavioral health condition, right? That 20% of the Medicaid population with behavioral health condition was responsible for over 30% of all primary care visits, 45% of all ED visits, over 50% of all inpatient admissions, and over 60% of the total cost of care in the Medicaid program in New York State. So that's that theme, the 20% of the population with a behavioral health condition driving 60% of the cost in federal programs. So we have to pay attention to behavioral health. Everyone has sort of come to that realization in the past couple of years. The ACOs now, as of 2016, majority of accountable care organizations now are including behavioral health initiatives, which means we have to measure performance. Now that we only have 15 minutes left, we can start talking about behavioral health performance measures. Sorry about that. The good news is there's not too much to talk about because we've lagged behind medicine. We don't have a lot of measures. Here's a couple of slides that list performance and quality measures that we have chosen in New York State for our VBP arrangements. The first slide has to do with measures in what we're calling our primary care quality measure set. So these are performance measures that are more relevant to primary care medical practices where people with mild to moderate conditions are often treated, right? The bulk of treatment for mild to moderate anxiety and depression is provided by primary care, non-behavioral health specialists. So look at these measures. Screening for depression and follow-up. Antidepressant medication management, that's a HEDIS measure. You know, what percentage of people with a new diagnosis of depression are getting an antidepressant medication for 3 months? What percentage are getting it for 6 months, right? Screening for tobacco use and cessation interventions. Diabetes screening for people with schizophrenia, bipolar who are using antipsychotic medications, right? With a number of substance use related measures, follow-up after visits to the emergency room for mental illness. So these kinds of very broad sort of tip of the iceberg measures, if you will. Here's the measures that are more relevant to the seriously mental ill population. Adherence to antipsychotic medications if you have schizophrenia. Follow-up after hospitalization for mental illness. This is the probably most popular, if you will, most widely used behavioral health outcome measure over the past 20 years. It's a HEDIS endorsed measure. The measure is if someone's coming out of a psych unit, discharged to the community, what percentage of those people have a visit within 7 days of discharge or within 30 days of discharge, actually 2 measures. More dollars have been assigned to that measure than any other behavioral health measure in value-based arrangements nationally. And you could argue, is that really a meaningful measure of the work that we do, right? But this is what you see. Most of these measures are tied to administrative databases, right? If you're doing a measurement-based program that's covering 50,000 or 500,000 lives, you need to somehow get data on all those people. How are you going to do that? The easiest way is to rely on administrative databases that states have or the federal government has, like Medicare bills or claims or Medicaid claims, where you can get information about every person. So you can get information about patterns of service use. How often do people visit emergency rooms? How often are they readmitted? How often do people connect with aftercare when they leave a hospital? So you'll see those themes and those areas of focus with these measures. That's where we're at as a field. Just to summarize, very few endorsed measures of key behavioral health processes that we would think are important, things like controlling core symptoms, engagement, retention in care, improvement or establishing family and supportive community relationships, recovery and recovery-oriented service access, personal and public safety. We don't have measures that we can use that touch on these important domains for us. So we have work to do. This is what we're going to do. So just touch on a couple of initiatives. Our commissioner, Dr. Sullivan, a couple years ago jumped in and said, we, New York State, the New York State Office of Mental Health, taking advantage of the fact that we have these research institutes, we got mental health services researchers who are worldwide experts, we need to create a measurement center, and we need to take the lead, both within New York State and probably nationally as well, in terms of figuring out how we can best measure quality and performance, whether that means developing new measures, whatever strategies you can. So she tasked us with creating a performance measurement center that went live about a year ago. And what I'm going to do, the rest of the talk, I'm going to talk a little bit about what that measurement center is trying to do and how we're wrestling with some of these issues in the context of a rapidly evolving system. I also want to put in a plug for the APA registry. The American Psychiatric Association has the PsycPro registry that many of you might know about. The APA partnered with NCQA and was just awarded a big contract from CMS to develop quality and performance measures linked to their registry work. So the APA is committed to developing quality measures related to things like first episode psychosis, measurement-based care, suicide and violence, so and functioning and recovery. So they really picked some major domains and have a lot of work to do, and hopefully we'll do some interesting work over the next 4 or 5 years. These are some key issues we're wrestling with. I'll illustrate those as we move forward. On this slide, we were told to create a performance measurement center. The first thing we did is we held a day-long meeting, a convening session. The CPI, Lisa's CPI Center supports convening activities where we bring in experts from around the country, around the state. This was 2 years ago, actually, this month, where we brought in about 60 or 70 people, including people in the room. Mark Olfson was there, et cetera. And we tasked this group, and Harold Pincus is here. Yeah, Harold's here. Harold is our unofficial guru for performance measurement. I have to say that, Harold. But we brought in these experts, and we tasked them with helping create an agenda for a performance measurement center. These are 3 priority areas that were established by that group. One is how to create either create data platforms or take advantage of existing data platforms to develop new and improved measures. Secondly is we need to start measuring functioning and recovery, especially since we are so committed to the population of individuals with serious mental illness. And we're committed to providing opportunities for recovery and improved functioning and independent living. We need to start measuring these things. And then thirdly, integrated care. We do need to remember that the majority of treatment for behavioral health conditions is provided by non-behavioral health clinicians, and integrated care models, integrating physical behavioral health care, are being promoted, tested, and validated. So how are we going to measure that? Here's an example of a bunch of measures that we promoted in the states, the New York State's Medicaid program. We initially went to the Department of Health and we partnered with them, and they've been great with us, by the way. We work with the Department of Health very closely on these issues. We said that for our seriously mentally ill population, we need to have measures related to things like employment, education status, housing stability, ongoing engagement in care, criminal justice involvement, right? We need mental health readmission data, et cetera, et cetera. It was initially a battle because we're fighting against the managed care companies, insurance companies, HEDIS, and federal regulators who say that you should not have any measures, you should not use measures in these value-based programs if they haven't been fully vetted, tested for reliability, validity, et cetera. And there's fundamental issues with some of these measures, like employment or housing status. Insurance companies say, we're in the business of health care. We're not the Social Security. We're not social services. We're not in the business of finding people places to live or jobs. We do health care. Now, we could have a whole nother talk about this notion of social determinants and this interest in how social determinants affect health. We don't have time for that now. But our position at the Office of Mental Health is that this is where we live, and this is where we have lived for the past 30, 40, 50 years. Longer than that, 100 years ago. We've been housing people with serious mental illness, right? Whether it's in our big asylums or now the 40,000 community supported apartment beds in New York State alone. So this is what we're all about. We have evidence-based practices for employment. IPS, the Individualized Placement and Support Model. We have practices that target employment as outcomes. We have critical time intervention, evidence-based practices targeting housing stability as an outcome. So we had to push back and say, no, 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 this is where healthcare is with behavioral health. Good news is we won, and the Department of Health has been very receptive, and we now have all these measures that are floating out there. The bad news is they said, okay, develop them. What's your numerator? What's your denominator? Where are you going to get the data? How are you going to do this? And that is very difficult work to do. I'll just illustrate for a couple of minutes some examples. So our measurement center is doing things. Here's a survival curve looking at this whole notion of engagement and care. If you come out of a hospital and you visit with a provider in the first 30 days, does it really matter? How much does it matter to connect with a provider once? What about connecting twice? What about 3 times? What about 4 times? What's a meaningful measure of engagement in that first 30 days? And here, the survival curve here is predicting time to readmission. The idea being that if you fail to engage, you're at a higher risk for being readmitted to the hospital, which is true, right? So do we find differences between people who have no visits in 30 days versus 1 visit versus 2, 3, 4 visits? We have to parse out. I mean, there may be a difference here between 1 and 2 visits. Maybe a better measure is 2 visits. This is not a finding that wakes you up in the middle of the night, but it's the kind of work we need to do, looking at populations of hundreds of thousands of discharges and teasing out these impacts. We've challenged ourselves. We talk a lot about engagement in care, engagement, because so many of our people disengage from care, and there's so many bad stories about people who disengage and then are involved in bad events and bad outcomes that promote stereotypes and stigma that we want to avoid. So what is engagement in care? We're actually putting together, our group is working on a conceptual model of engagement that includes all sorts of patient factors, enabling factors. It tries to describe actual engagement, which you can measure by attending visits or treatment alliance. But that's impacted by the effectiveness of the treatment. There's a cycle here, a feedback cycle. But if people do get engaged, you have certain intermediate outcomes that are important and certain longer-term impacts that are important. So here's a model for engagement we're very proud of. But now the question is, well, what do we do with this? If you're going to measure engagement, what are you going to measure? You're not going to measure all these things. How do you choose what to measure and hold providers accountable for? That's the other part, right? What can you measure, and what does it make sense to hold people accountable for? We have to wrestle with these issues. One of the things we're doing is stratifying measures. There's a lot of measures that have been out there and being used by hospitals over the past 10 or 15 years. These are measures of prevention quality indicators, PQIs, or readmission rates. I'm sorry, these are not readmission rates. These are admission rates, right? So PQIs, or potentially preventable conditions, these are conditions that with good primary care, good routine community-based care, people should not require inpatient stays. So asthma, right? If kids, young adults are getting good treatment for asthma, they shouldn't have to go into the hospital with an asthma crisis. Hypertension. People shouldn't be admitted with a primary diagnosis of high blood pressure, right? Heart failure. almost all people with heart failure, you should be able to manage heart failure in the community. So these have been labeled as what we would call potentially preventable admissions. Hospitals nationwide have been either penalized or incentivized for these rates for 15 years now. And if you look at the non-mental health population, the orange bars, the rates have been driven down very low. So CMS is saying, well, we need to retire some of these rates, get rid of them. They're no longer useful because we've done what we wanted to do. We've got hospitals' attention on them, the rates are low, this is good. But we jumped in and said, hey, this is the first time anyone's doing this. Look at the same rates, but look at it in the mental health population. Look at it in people who have a serious mental illness. And look how some of these rates are sky high and going up tenfold. So can we keep some of these rates but stratify them? And then the last set of slides I'll show have to do with measuring functioning and opportunities for recovery. This has been a tough one for us. We do have this HARP special needs program in New York State. There's about 150,000 people with serious mental illness who are being enrolled in these special needs plans. Long story short, there's a federal requirement that people in these insurance plans have to have annual functional needs assessments. That's a federal regulation that has to do with how they've structured the program and how they create access to what we call home and community-based services. We jumped on that 5 years ago and said, hey, if all 150,000 of these people are going to get annual assessments, can we build those assessments such that they will yield data that we can use for quality and performance measurement? And that's what we did. Long story short, we got about 150,000 people in these special needs plans statewide. We've only been able to get the assessments completed. These are early data, 16,000 people. We're upwards of 40,000 now, which is a nice big data set. But if you're going to develop quality and performance measures, you need data on everybody. You need the great majority of your population has to be assessed. And because of the way the health home and the managed care programs are structured in New York State, we're having a hard time getting these people enrolled, getting outreach, getting them assessed. That said, what I want to do is illustrate some of the data points and potential measures we're thinking about. One, obviously, is employment status. To this day, we still run, 90, 95% of people with serious mental illness are unemployed. And we have to move that needle. We've got individualized placement and support programs that definitely move that needle. We have to promote them, and we definitely are considering some sort of employment-based measure, whether it's seeking employment or unemployment, that we're going to introduce into the value-based program in the next couple of years. Homelessness, housing instability. This touches on another key issue, which is you have to define things the same way. You can go to any of the 150 hospitals in the state right now and look in their medical record and see how they document housing status, and 150 hospitals document it 150 different ways. That's one of the problems in our healthcare system. We're trying to rectify that with a lot of the EHR initiatives. We have to start standardizing definitions for some of these social determinants, if you will. So we have a nomenclature or definitions of 8 or 10 different levels of housing stability or instability, right? Can we do that? Incarceration, right? This is looking at our population. Again, this is a convenience sample. We're up to about 40,000, but that's not the point. The point is 4 to 6% of people with serious mental illness in the special needs plans who've been arrested, incarcerated in the past year, but over 40% lifetime. So these are people who do cycle in and out of the civil and criminal justice systems. We know that. We have to measure that. How about indicators of violence? This is a tough one for us. There's a lot of stigma out there. There's a lot of stereotypes that people with serious mental illness are violent, inherently violent. And every time we see one of these awful episodes, these mass murders, et cetera, some of them clearly appear to involve people who clearly seem to be psychotic. And everyone, all the politicians, et cetera, jumps on that and says we have to do more to get the seriously mentally ill off the street. No, we have to do more to address access to services and stigma and stereotypes. So that said, we got to be very careful with what we measure here. But people do report rates of violent ideation, intimidation, violence to others fairly low. Trauma-informed care, that's an important concept for us, which begs the question of, can we start getting some sort of index of the stability of people's social environments and systems? So can we start tracking life events for people either within the past year is the blue or lifetime. So we can get some sort of index of social environment stress or trauma in their life. These are the data that we have. We just talked about people with serious mental illness being involved in violent episodes, much more likely to be victims, right? Over 30% have been victims of sexual assault lifetime, over 40% victims of physical assault lifetime, 40% major hardship due to poverty. And again, it's past year versus lifetime. This is a population of people that, by and large, live in very stressful times and environments. And we're wrestling with ways that we can capture that and try to create measures that we can point payers and providers to help them try to address. Perception of care, I'll finish with this, very relevant and important focus on engaging individuals and measuring their perception and experience of care. We developed a perception of care survey. This is from our first pilot study on perception of care. We've done another pilot study on it so far, but the initial study, and again, it was a convenient sample, but people did endorse, patients participate in community mental health programs, did endorse feeling that their providers listened to them. They rated lower, however, whether they felt they had an opportunity to affect goal setting in their life or whether they were able to do things that they wanted to do as a result of their treatment. So more to do there. We've sort of touched on suicide and violence. I'll skip on that. If people have questions about it, we can talk more about it. Very interesting things to discuss. And here's the future. Patient-reported measures, e-measures, electronic health record measures. We need to figure out how to move away from claims and other administrative databases to get measures and pull data directly out of electronic health records, data that are much more meaningful and reflect the subtle contextual factors that are important to people and outcomes that are important to us. Burden is a huge issue, actually, and here's a cynical slide, but I thought I'd put it in because it's funny. The skeptics will say that, well, this skeptic reinterpreted our triple aim as the triple lame approach, where our focus on experience, outcomes, and costs has actually created a wheel on the healthcare vehicle that doesn't work anymore. And what we now have is the capitalists. These would be our people, I can say this, over next door at New York Presbyterian, running their hospital, doing fine and well, thank you, with their heart and lung transplants. Versus our provider system, this I think is Jeff, and those of us struggling day to day with the burden of trying to survive and adopt all these changes and measure all these things and all these intrusions on our day-to-day life. And then these guys, I don't know who these guys are. I see them in the hallways every day now. Guys who look exactly like this, young guys with tattoos, and they're glued to their phones. And they're always smiling, and they're everywhere, and they're always fiddling with our computers. And you get the sense that they are the ones that are driving the healthcare system now and not us. So we'll see. We'll see. But let's not end on that. Let's not end on a cynical note. To summarize, this is all I've been saying. These measurement-based approaches are going to be very critical. They're definitely happening. We need to understand them. Behavioral health has lagged for a lot of reasons, but we're not lagging anymore. We're front and center, which means we have to take advantage of the opportunity to identify outcomes, care processes, interventions, populations that are important to us and figure out how to measure these characteristics and get them in front of the key payers, regulators, et cetera. So a lot of work to do. It's a big focus area for the Office of Mental Health. I'll stop with that. So thank you.
Tom, that was amazing. Really very, very impressive. At the same time, also sobering. Let me start off by asking two questions. First, the history that you've sort of portrayed well, actually, first, before I do that, I just want to say that in the context of what I said before about Tom's role in sort of bridging between an academic medical center and a public mental health system, he is an exemplar of a cadre of faculty who have historically done it and continue to do it. And it's really wonderful because it's exactly what we're supposed to be doing in terms of, providing a pathway for new knowledge and training and better care from a engine of discovery and knowledge to a healthcare system. And years ago, before I arrived, John Oldham actually was the chief medical officer. He used to go up to Albany weekly to represent PI in this process. Now we have Tom, Susan Essick played this role. Lisa Dixon is really kind of a sort of foundational figure in terms of the dissemination. Scott Stroop, Harold Pincus sort of co-founded this indicator
Center, yep.
laboratory
Yep.
with Tom. Numerous people. Mark Olfson has successfully mined the databases that the state provides. So I wish all of our students and trainees were here to see what the opportunities are, because I know there's many people who are interested in, as Angela says, having purpose-driven careers, which can influence, the course of events in our society.
This division didn't exist until 2007. You recruited Susan Essick, who created the Division of Mental Health Services and Policy, and now, 12 years later, I mean, it's a dynamo.
Exactly. I mean, that's the difference between the ivory tower sort of giving back and providing, a full realization of the public-academic partnership rather than what too often has existed. But just to, put you a little bit on the spot further, it seems to me that a lot of what you've described in this historical evolution of the way healthcare is provided, financed, and monitored has been a largely unsuccessful but yet continuing effort to provide cost-effective quality care, but in the absence of a top-down, enlightened government policy. In other words, at the ground level, whether it's the providers, the payers, the state or local government agencies, they're struggling to develop something in the absence of a national policy, which is coherent and enlightened. Now, we can't do any of this above our pay grade, but it seems to me that that situation or that aspect has made the process much more challenging than it might otherwise have been. Second thing is that I don't know all the acronyms, but you have ACOs, you had DRGs, you have managed care,
DSRIP.
you have all these different sort of systems, and that are trying to somehow incentivize the providers to be providing cost-effective care. And then it all rolls up, or should roll up, to population health in some way and going at risk. So where does that fit in?
Well, you said a lot.
It's really two questions. Is the impediment of a lack of a coherent national policy on healthcare, how healthcare should be financed and provided at the federal government, is that an insurmountable impediment or not? And then secondly, what about all these different mechanisms, DRGs, so forth? What about some way of mandating a population health going at risk policy for providers that are taking government money?
Yeah. I mean, we certainly live in a funny country and very funny times right now in terms of federal approach to healthcare. I think the Affordable Care Act, which everyone thinks of as Medicaid expansion and exchanges and everything, I think what's understated in the Affordable Care Act is how it outlined a vision, a national vision for population health and this move towards value-based payment and a fundamental redesign. So I think we had that briefly under the Obama administration, and we still have it, and the Affordable Care Act still exists. However, from the day it got approved, it's been under assault, right? Mainly from the Republicans who just disagree in principle with some of these foundational notions that we should aim to ensure everyone, if we can. We should aim to ensure that all Americans have equal access to care. I mean, these are some fundamental ideologic positions where the schisms are so great in our country, and you know, and especially right now, you know, with the current administration, you really have to just sort of keep your head down and do your work. The good news, if you will, for folks like us, you know, mental health services researchers, is one of the things that Susan taught us right away, is that when things are going great and there's a lot of money, you can get really innovative and do some very clever stuff. But when things are going poor and there's chaos and there's less money, then you can do some really innovative stuff, because all the powers that be come to the services people and say, hey, this is chaos. We have to make do with less. We still have to redesign. There's actually more incentive to do things when things are chaotic and hectic, because everyone's trying to save themselves, if you will, or save whatever money they can. So there's been plenty for us to do. The good news about the federal government is that it's so, in Congress, is that they're so dysfunctional right now that, you know, we sort of laugh and roll our eyes every time they talk about repealing Affordable Care Act. If we put our pencils down and stopped every time we heard word that everything was going to be pulled, we wouldn't have done anything for the past 10 years. But look what we've done. We've done a ton of stuff in New York, because in the end it's survived. What's sad about it is that New York is a great state. It's a big state. It's a very wealthy state. It's always been very, very democratic and welfare-oriented in the best sense of the word, welfare. So there's always been opportunities to innovate and do things. And New York, you know, signs up for every federal initiative. So this wonderful laboratory to do things. What's really sad is that you don't see that in other states. And in half the states, especially red states in the South and the West, they have nothing. Not only do they have no money allocated for any of these initiatives, they have no political will, they have no interest. You know, it's literally in Texas, if they had more money, they'd get more guns in people's hands. That's their priority. So it's when we interact with our peers in other states, when we see the quality of the Medicaid program, not that we have this great Medicaid program, but relative to what's out there, that's very sobering. And what they say about in the United States, if you've seen one, you know, state Medicaid program, you've seen one. There's 50 different states, and it's all so different. I'll speak for myself. I would love to have a single payer system with federal standards that applied nationally, where we could do, you know, roll out some of these initiatives. That's not going to happen. Not anytime soon. There's some talk about it maybe in New York State, but there's so much motivation against it that I don't think that's going to happen. But there's plenty of room to do stuff, and we're doing it. And people like myself and our division, I think our division does good work and has good people, because people have seen opportunities to come into the Psych Institute and collaborate with the state. We've had great leadership with Mike Hogan. We got good leadership with Ann Sullivan, who's brought in a lot of psychiatric staffing. So if you just keep your head down and stay out of the higher level mishigas, we do fine.
And what about the risk and population assumption of risk mechanism?
To be determined. You mean the idea of whether this population health focus and provider systems taking on and actually dealing with risk?
Yeah, I mean, everybody talks population health now, but there's no enforcement of it. And certainly, you know, NYP doesn't practice population health. So if there was a process or a mechanism by which providers who were getting government money were required to go at risk to some degree, you know, you get out of the quality issue. We're not measuring your quality, we're not measuring your money, we're just assuming you've got to be responsible, and we're paying you a capitated rate or something.
It is happening. Montefiore's doing it. Maimonides is doing it. Health and hospitals, you know, they're their own system, but they're having to wrestle with it. It is happening. It is not happening, and it will not happen at New York Presbyterian. New York Presbyterian is one of, 10 or 20 hospitals in the world that can get away without having to think about population health, prevention health, and fundamental redesign of its mission and focus. New York Presbyterian doing very, very well, doing quaternary care, right? That's what they call it now. They don't have to worry about primary, secondary. They don't even have to worry about tertiary care. So their model is working very well for them. They're thriving. They got more money than anybody. There's no incentive for them to do this. But they're literally, probably 10 or 20 hospitals in the world. Healthcare systems differ so much. But certainly in the country that can get away with that. But the other thousands and thousands of hospitals haven't been able to. And they are making those shifts. So I think there's one. Welcome to America. There's two American healthcare systems, just like there's two Americas in every arena.
Yes.
Thanks, Dr. Smith. So my question was about the second person riding that dysfunctional bicycle, the clinician.
Jeff?
Not necessarily Jeff. I was more thinking about it from our perspective as residents working in OMH facilities.
Yeah.
And I think all of us are of two minds about it. I think we're disappointed at poor quality of care in the community, disappointed at how our patients are monitored for things that we consider to be quality care, metabolic parameters. And then on the other hand, we do have a lot of initiatives that take up a lot of our time.
Right.
And you touched on the question of validity and reliability. I think I'm not admitting to anything or trying to rat anybody out, but I do think it suffers under the burden. I think things accumulate, quality assurance, quality improvement initiatives accumulate without revision. And I was wondering if there's any effort to involve providers in the conceptualization and implementation of these tools. There are people like you who study it and try to disseminate it, but a feedback system between clinicians and the people who are trying to disseminate it seems critical for a variety of reasons.
Yeah. We need, I think part of the pessimism here, right? This is a practicing clinician, the doctor with the white coat. I think part of the pessimism is that the physicians, the docs, the providers have been burdened with all these new activities, reporting activities, et cetera, but they haven't been involved to the degree they should be in the conceptual design, the approach, the implementation. So they have the worst of both worlds. They have to do all the extra work, and it wasn't their idea, and they're not convinced it works. So this is a real issue. You go out into community hospitals, and I spent 6 years at a community hospital as a director of psychiatry and CEO for a couple years. It's tough out there, and the providers are just beaten down by a lot of this stuff. So I think we, as a field, hopefully our medical schools will pay better attention to this. You're seeing more medical students getting public health training or coming out with masters in public health. We need more physicians, doctors, in leadership roles, whether it's with state, regulatory authorities, the feds, insurance companies, designing these initiatives. Because if you got quality improvement people who don't know what it's like to treat a patient, designing a patient flow and clinical pathways, it doesn't work. So yeah, we have to get better. As I said, we have to train more people. We have to empower and authorize ourselves and our trainees to get involved and get into these roles, et cetera.
Lou? Don, thank you. It was great overview. So it's somewhat narrow question, but I'd like to hear your comments about it. So at the beginning of the talk, you mentioned volume and value, right? And I think what I have experienced is that mindset has been pretty pervasive. They automatically, so a lot of people, it's black and white. Either you have volume or you have quality instead of, not in addition to. Once in a while, I see some people trying to reframe that volume isn't necessarily antagonistic to value. Mm-hmm. If you're providing high quality care, the more people you see, the more value you're providing. And I think sometimes the mindset does affect the system because access is still a problem. And sometimes becomes almost an excuse. The low volume is because we're providing great, high quality care. Right. So what's your take on it?
Right, I think we're getting into these shades of value, et cetera. Right, and I think in the end, perhaps the term we ought to be using is efficiency. That really, if you get more efficient with your care, you can see more people and deliver better care. Value, I think, more and more does imply cost in dollars, And that still just doesn't sit well with most providers who think that, well, I'm just working so other people can make more money off me. So I think, so number one, I think we got to make sure that clinicians and providers see those dollars, by the way. But I think the notion of efficiency better captures the idea, better captures notions such as access and retention in care. Because it's one thing to do a really good job in, this half an hour, in the operating room, for example, but it's another thing to not have any complications, that the person die the next day, et cetera. I think we have to pay attention to the longer episodes of care and these key issues of access, engagement, least restrictive environment. When do you move people down to levels of care? We have to incorporate those notions into our measurement activities and into our workflows, yeah.
We've got a bunch of questions, so we're going to take Harold and this gentleman, and then Steve and David.
Really nice job, Tom, in terms of looking at the span of activities that are currently being initiated and have been going on for some time. Just 2 points. One is, the issue before about the guy in the middle. Actually, people have moved to not so much the triple aim, but the quadruple aim.
Yeah,
and the
that's
quadruple aim is actually the health and mental health of providers, to actually include that in the whole framework. And so that's where things are moving in terms of thinking about exactly that guy in the middle. Number two is a lot of what you've been describing has been like really innovative activities within OMH and DOH and the state level. But most of us are insured by in the private sector.
Right.
We're insured by employer-based insurance companies. And to what extent does the state have any influence there? Is there any way in which they're trying to they're enabled to make changes on that side of things?
We just had a meeting this morning, the executive team at OMH in our weekly meeting came up. I think there's going to be, you're exactly right? We oversee Medicaid, Medicare programs. Commercial payers tend to keep a close eye on what's going on in Medicaid, Medicare. They'll hang back and see what works and what fails in Medicaid, Medicare before they adopt it in their own programs. So there's that general theme. But what we were talking about this morning is parity. New York State is going to make a major push to really enforce the parity laws, especially related to behavioral health. And so in New York State, there's the Department of Health, which oversees the Medicaid, Medicare programs. Commercial insurers are overseen by DFS, Department of Financial Services. So they don't even, I'm not sure they have very few clinicians or clinical administrators at all. It's the fiscal financial folks who basically push dollars out to, well, they don't push dollars out. They regulate, set the rules for commercial plans who want to operate in New York State. But we've got some synergy and communication between DFS, DOH, OMH, and OASIS, where all agree that when we do our parity work, and I got a little nervous this morning because it's going to be a ton of work for us. One of the things they want to really go after is utilization review, utilization management in behavioral health. And they want to go after the commercial plans. They want to look at what's going on and collect data. And the feeling is at the highest levels in New York, this didn't come from us, that the plans aren't doing it, that we don't have parity in behavioral health, and that we need to do something about it. And Governor Cuomo wants to do something about it now with commercial plans. So we're going to ask me a year from now.
Yeah. By the way, I
So
would
just
to let
we
you know.
have 5 minutes, and we have 3 questions. So let's see what we can do.
Sorry.
Let's start here, and we'll try to do them quickly.
Thank you. That was a great talk, Tom. Just, I'm curious for your musings on a little bit what Dr. Pincus mentioned on the workforce. We are seeing a large part of the workforce possibly retiring in the next 5 years, and you've told me your concerns about the community-based agencies. I'm curious about your thoughts and your concerns about how to think about this transition in terms of what's happening with our current workforce.
Yeah. That's a lot of musing that I won't do now. Workforce is a huge issue. We have entire sectors of the healthcare system that are relatively new. Best example being care management at the health homes, et cetera. There's an army of care management entities out there, and it's an entire new sector of the workforce that we're trying to get up to speed. The APA recognizes the aging psychiatric workforce is trying to do things about it. There's a lot of focus now on physician extenders. Psychiatric nurse practitioners are everywhere these days, right? There's all sorts of discussion about that, and great training programs. So I'm musing. This is the topic of an entire grand rounds, the workforce issues, the shifting roles and responsibilities of the different sectors of the provider system in the context of all this reform. A lot we could talk about, a lot going on.
Dave Forrest?
So as we're fighting the good fight here and making these hard-to-get incremental changes, I'm struck by the dramatic difference in the comparable other countries. What is their secret sauce? We don't hear about physician burnout, and they don't seem to spend any money, and they get great results. Are we trying to invent the wheel, and we could just sort of spy on them and do what they do, or why? What's going on that we can't do anything?
Well,
like
number one, 2, 3, 4, and 5 on the list are single payer. So many of these countries, not all of them, but so many of them have single payer systems where you got a single set of regulation standards. You've got a single vision for the entire healthcare system. Our healthcare system is, driven by our capitalist model, and the incentives are just all over the place. So that's numbers 1 through 5 on the top 10 reasons why they do better.
And last question, Steve Heiler?
Okay, thank you. Hi, Tom. I'm glad you're there to do the good fight. You don't have one important person here, which is the cynic. And the cynic is the person that's been around long enough to have gone through the different political phases that include things like deinstitutionalization, managed care, relative values, and et cetera, et cetera. It seems like there's a new political initiative.
Yeah.
I guess it gets you cynical that, gee, if we keep the current system, nothing is really going to work. It's really like a deck chairs on the Titanic thing. Just for example, in the first slide or so, you showed that the U.S. is way behind in terms of things like as simple like longevity. Mm-hmm. We trail by 5 years the other industrialized countries. But think about it. If the population in the U.S. stayed alive for 5 more years, things would not get cheaper. They would get drastically more expensive as we pay for care for those 5 extra years. So that could make you cynical. Yes, we'll be 5 years older, but we're going to have to pay for 5 more years of Medicaid, of Medicare, of medications, of hospitalizations, and it's going to shoot the costs up to the roof. Without changing our basic assumptions, how do we expect any real change?
Yeah. I think so. I don't, people do talk about things like single payer system, et cetera, but I personally, and I'm not a public health expert by any means. I work for the agency. But my feeling is that that's not something that's going to happen soon. I think there have been incremental changes. I think our healthcare system also does great and wonderful things. And if I got really sick, I would probably get my treatment in the United States. I don't think I'd go over to London to take advantage of their single-payer system, right? If I had my heart disease or something, I'm not. I'm getting my care here. So there's a lot of good things about our healthcare system. I think if you go back 50, 60, 100 years, there's been incremental changes, right? The creation of Medicaid, Medicare, Social Security, et cetera. There are things that happen around our healthcare system that have been very good. I do hope that 50 years from now, people will look back at the Affordable Care Act and say that it did drive the uninsured population down from 20% to under 10%. That would be very, very significant and get us closer to being a country where everyone is insured. I think there are things that are happening with each of these, shiny new objects. You're right. Every 10 or 15 years, there's a new one. But I think we have good enough people trying to implement them, and that there's incremental changes that come out of each of them that overall make us a pretty good healthcare system. It's easy to criticize, but.
Well, thanks so much, and we're very optimistic about your assuming this new role, and thank you for pinch hitting today.
Sure.
Please join the residents upstairs in the multipurpose room if you have more questions and for lunch.